So there we had two different surgeons using very different technology, but achieving the same thing in a pretty effortless way. And that leaves us a few minutes for questions and further discussion.
So I just want to comment real quickly on stuff that's come over chat while we were going through the procedures. Excellent job laying out both the navigated and the fluoro procedure, which is capable with the Rialto system. Dr. Beck, you in particular, it's funny. I don't know if you paid these people to get on here tonight or if they just truly, truly love you, because I think you have some patients on here that got online and they are truly grateful for what you've done for them. Giving them their life back was one comment. Just the whole thing around the procedure, the posterior approach, seems to be the differentiator within how these patients feel after their surgery. And I know, Dr. Benalcazar, you used to do the transgluteal approach.
Yes.
And you have a significant subset of patients as well. Can you elaborate just a little bit on two things? And one of these is a complete panel, but Dr. Benalcazar in particular, elaborate on your usage of or performance of the transgluteal approach versus what you've experienced with the posterior approach. And then number two is more around, well, just answer that one first and we'll come back to the second one.
Okay, well, the transgluteal approach, basically, it was a lot more awkward for me. It took a lot longer. I was not in a position, a lateral position that I do any other procedure in, so that's where some of that comes from. But more importantly is the amount of blood loss. You could see the blood loss on the navigated surgery that I videoed. I mean, there really wasn't any. But the amount of blood loss for the lateral transgluteal muscle approach, was significant. And in terms of pain right afterwards, for the posterior approach, the Rialto, I don't have any restrictions on the patients. I have them fully weight bear right away, have them get up, move around, really enjoy their new pain-free status, if you will. For the transgluteal approach, I had much more significant postoperative pain, and I just don't see that with the posterior approach. I think the number one reason is the avoidance of muscular disruption.
Dr. Rubin?
Our average blood loss in the transgluteal was somewhere between 150 to 250 cc's, and that's, for me, excessive, especially when the average blood loss through this new posterior approach is less than 20. So it's not an issue anymore. And even when people poison their platelets with all the different things, goodies, powders, and all these other things that they don't claim and to take, and we just don't have to worry about reversing abnormal clotting from people who take medications that eliminate the clotting cascade. It's a non-issue because you're not messing around with muscle.
And you have a direct visualization, so if something is bleeding, you can see it.
Right there.
Yeah, so this is probably the right time to talk about our post-op protocols. There's obviously variation. I basically instruct people the way I instruct a lumbar microdiscectomy. I do it as an outpatient, both procedures, and I tell them go home and take it easy for 6 weeks and don't stress the joint. And I'm not a whole lot more specific than that. I said if it seems like something you shouldn't be doing, that's probably true. And it's something that it's like you're trying to get bone to heal. It's like you broke your arm. Be careful with it. What do you guys tell them?
I couldn't agree more. I don't restrict their activity. I want them to increase their activity. I want them to retrain their muscles. I want them to take normal strides. I want them to begin to act and walk like a patient without an SI joint problem.
So as a teenager, if I could get away with something without my parents knowing, I would do it. My children, I handled the same way and learned that if patients want to do what they want to do, they will. So we try to over-caution them, accept the fact that they will push it, and if they feel good, they're going to do what they want. So we start them off, we pre-train them to do toe-touch weight bearing, which was the old standard way with the transgluteal approach. I think it was probably because we wanted the gluteal muscle to heal faster, or I'm not sure, but that's how we handled it. I think that once it's stable, because it has such a limited arc of motion, because once it's stabilized through 2 implants going in different planes, and because of the geometry of the joint itself, it's probably something that, quote, if you would take it easy, if you don't try to jump off an 8-foot ladder the first day and you just go slow, I think it's probably the way to go. But for me, right now, I'm having all of our patients do toe-touch weight bearing for 4 weeks and then throw the crutch or the crutches or the walker away and have at it.
You know, I really agree with something you said. I think that with the proper biomechanics, this joint is probably actually very easy to fixate.
I think so.
And it's a very, actually a stable joint, but you have to have the right forces, and the Rialto seems to be the answer to it, which is why those things aren't coming loose, and the patients get pain relief quickly and aren't having a too bad of a recovery. As far as outcomes, which is probably our last subject here, none of us have 100% success rates, and it's a matter of study to try to figure out the 10% or 15% that haven't responded, and that's also true with other elective surgery for pain. Nobody's got a 100% success rate on anything. But in general, would you say that the success rates with this are comparable, better, inferior to some of the other things you do commonly?
Well, I think that this is a great procedure. If you take your time, you get the right patient. It's always the right patient who's motivated to get well, who doesn't have issues that you can overcome through your surgical skills and techniques, who's going to be compliant, who wants to get well. I think we're seeing patients who really dramatically changing their life. They just are so happy, and you end up being a superstar because you found what's wrong with them and you fixed it, and they're happy and they get to return to their normal life. It's a big deal.
Yeah, I think arguably the best fusion procedure that we have that's been time tested is the single level ACDF. Sure. And this Rialto procedure is right up there with that. And so is it perfect? No, of course not. Does it depend a lot on the patient, on the diagnosis, et cetera, et cetera? Yes, but everything being equal, I think we have a procedure that's going to rival our single level ACDF as the most successful in our arsenal.
And I think we're coming to the end here, and I agree with everything these guys said, but we're all sitting here because we care about these people and because this was a neglected population, and it makes me sad to think back about 10, 20 years ago and a lot of the patients I saw that I had nothing to offer. And, I think...
You knew they hurt. You knew where they hurt.
Yeah.
But you just couldn't help them.
Yeah, and it makes me sad. And I think, I'm really happy to be able to sit here today and say, we have something to offer. It's not perfect, but it's really darn good, and we're proud of it. And Medtronic has done a really, really nice job with this, developing this surgery. And I hope it's gonna be something for all mankind, at least for the foreseeable future.
I agree with that. Yeah.
So when you're looking at a patient with chronic pain, that pain is down at the lumbosacral notch, and they've seen everybody else, and you ask them, well, did anybody examine you and check your SI joint? And they say, well, I don't know, I don't think so. And all of a sudden you consider that as a potential option for their chronic pain. Go test it, because you're going to make them happy, and you're going to do something that nobody's ever thought about or considered it, and it's worth the effort, and It's a minimal effort.
And I would also say, don't be afraid to take the lead on this. Don't expect necessarily that your pain management doctors in the area would have already figured this out, would have already diagnosed this, that your physical therapist would have already diagnosed this and figured it out. If that were the case, we would never have people who've been walking around for 10 years with this problem undiagnosed, and that's exactly what we see.
Wish we had a live audience, would take more questions. We like to talk about these things.
Just to interject, there are so many things that have come across the chat. I'll say it again and again. The patients who have had this procedure love it. I think you guys can attest to that. You nailed it right on the head when you said these patients get better, but you also don't make them worse if it's missed, right? So I guess in closing, this was a phenomenal event. This was the first of its kind for Medtronic, and we sincerely appreciate you guys, your contributions to this procedure, to the advancement of this continuous education. I hope that everybody takes away something very valuable from this program. We look forward to doing this again. This was fun. This was a lot of fun. I was standing back there having a ball.
And we had a good time.
Yeah, it's,
We like each other, and
I'm glad.
we worked hard today. We had a good time.
We have a procedure, and you guys said this. This is not me, promotional guy, saying this. We have a procedure that works. These patients get better, and that's awesome. And so I'm extremely excited about what went on tonight. The conversation was fantastic. So thank you to everybody, global audience that attended, those in the room. Thank you. With that, we'll just say good night. And if additional information is needed, contact your Medtronic rep. Contact Medtronic Spine headquarters in Memphis. If you don't have a Medtronic rep, other than that, thank you for attending once again, and thank you to our faculty. So let's give them a round of applause.
Thanks, brother. Let's stand up.